invited me here. So what is our experience? Basically, I would like to criticize a little bit this as a guideline because I'm not 100% sure it's correct to keep the patient like this with such huge hyperperfusion area on best medical treatment. In our practice, it's an indication for angioplasty. And what we are talking about a group of nearly 10% of strokes patient, and we know that recurrence of stroke is up to 23% per year. And now, just recently, it was published meta-analysis, and regarding the short-term mortality and stroke rate, there was significant lower in pulmonary angioplasty group, as you can see here. But we know, it was mentioned several times today, that we can divide the intracranial stenosis according to Mori classification. And we know the restenosis rate of type C is really high. However, there was only 3 patients, so it's difficult to make a really serious conclusion. And we also know that Sampris trial failed to show that angioplasty versus best medical treatment is better. But we need to criticize the experience. There's only minimum 3 procedures. The monitoring after procedure was not perfect. As well, the loading dose was problematic. It's associated with a high risk of bleeding, and the timing of procedure is as well problematic. And if you compare this medical group and stenting group, you can see that the major difference you can find in first 30 days. So what is the key to reach the better results? It's to decrease the complication rate during the procedure. And we know that surgery is not the alternative for this patient. So what can we do? Who is the good candidate probably for endovascular treatment? We know it from VASIT trial is a stenosis patient with a stenosis more than 70% with recent symptoms, and women are at high risk. And so that's the reason we accept the indication stenosis than more than 70% symptomatic. If there is insufficiency of circular villus and non-collateral flow, and we also accept dissection. And again, if you look to WAVE trial, if you select the patient properly, you may reach much lower complication rate, or less than 3%. This is the final result of the WAVE, and you can see that yes, the complication rate is lower comparing to previous. So basically what we can do, if there is a symptomatic patient like this one, we can, in M1 stenosis eccentric, so we do angioplasty and we put the stent in the same session like this, and you can compare images, 3D navigation, and final angiogram. And as you can see here, you can clearly see the perfusion immediately, improvement of the perfusion immediately after the angioplasty, and you can see also the curve of perfusion curve before and after the procedure. So we can find several ongoing trials. Some of them are finished. And regarding the timing, you can see the meta-analysis. It's better to treat the patient after 21 days after the event, because otherwise the complication rate is higher, so it's a recommendation. Regarding technical tips and tricks, first of all, we need to avoid some complications. How to select the stent, and we need to play how to inflate the balloon, and post-dilatation is also a good question, how to do it. We learned that hemorrhagic complications are associated with a high percentage of stenosis, lower MRS, and what is the most important is the last sentence, that if you load the patient with bolus antiplatelet therapy, is associated with a high hemorrhagic rate of complication. Regarding ischemic risk, patients are non-smoking, basilar artery stenosis of the perforators, and diabetes, and as well as older age. And this has a good impact to China study. They accept the patient after 3 weeks after ischemic symptoms, and they use the ACT less than 300 seconds. They use self-expanding stent, and they achieved 1 month stroke or death rate only 2%. And it's also complication rate depends on how do you make a definition of the complication. If you look to another China study, they included 5 patients as a complication with a TIA. So if you look to long-term result, is it really a big problem if the patient has TIA and has a good result then after? I'm not sure. And this is a point you can find the difference in different studies. But basically, they achieved also interesting result. If they used self-expanding stent, the percentage of restenosis rate was lower compared to balloon mounting stent. And if you look to another review in the literature, you can see some tendency that self-expanding stent has a little bit lower complication. It's in this study it was up to less than 10% compared to balloon expanding stent, and here you can see the restenosis rate in comparison. If you can compare two groups again between balloon expanding and self-expanding stent. So of course the complication rate depends on type of the lesion. It's recommended to inflate balloons very slowly, a little bit undersized balloon, and probably according to this result we can say self-expanding stent is probably better. But of course we need to have the data from the long-term results, and the question is if it's good combination to combine balloon, the regulating balloon with a stent or not. We don't have sufficient data for this. Another article referred that restenosis rate was due to longer stent usage and balloon mounting stent, and I'm not sure the local anesthesia can have some impact to this, but it was reported by authors. And what we see in this another study, so basically self-expanding stent is better for because it's more flexible, and it's good for tortuous vessel. Comparing to balloon expanding stent, there is basically maybe one advantage. If the stenosis is highly calcified, so in such case probably we can use the balloon expanding stent, but we usually we need to use very short one, and another problem is usually it's necessary to take stiffer guide wire. It's a problematic. So again, another list of studies. You can see that nowadays we can reach let's say a high rate of technical success, nearly near to 100%, and it's recommended to undersize to use the balloon a little bit undersized and use self-expanding stent. Another study, again, 30 days complication rate was 2.2%, and this is another study. What is interesting that they used, they included nearly 50% or 45% in posterior circulation. We know that posterior circulation is a risk factor if you treat basilar artery occlusion. So, but they were able to achieve to reach fatal procedural stroke 2.6%. Another studies from the China, they used both balloon mounting stent and let's say over the wire self-expanding stent, The advantage of balloon mounting stent was a shorter operative time, but it's not the case if you can apply the stent via the balloon. And again, another study, they confirmed shorter operative time, but again, they compared this procedure with the over-the-wire system. And this is the recent, not so recent, but a new study. They recommend, authors recommend to postulate self-expanding stent due to better stent expansion and apposition, and probably it's associated with less thrombotic events after the procedure. So what is our technique or our recommendation? We prefer to use soft tip guide wire. So if you use the balloon mounting stent, usually it's necessary to use a more stiffer, and it's a risk if during the delivery, if the guide wire jump a little bit more distally, it may lead to perforation of the artery. So that's our strategy. We prefer to use angled guide wire. Hydrophilic coating, of course, is recommended to catheterize inferior M2 branch. And time to time, if it's really necessary, we navigate the guide wire with microcatheter, and you can use the microcatheter to inject the contrast media to be sure that we are interluminally. And of course, it's recommended to reduce exchange maneuver. So placement of the stent via balloon is a good option, and probably it's better, at least for tortuous anatomy, to use self-expanding stent. So let me show you the case. It was symptomatic patient with diabetic hypertension and fell after antibiotic therapy. And you can see the tandem stenosis at the origin, and also intracranial on the right side. So we decided to perform angioplasty in just local anesthesia extracranially in the first session. But the patient was still symptomatic, and you can see the venous phase or delay of the territory of the middle cerebral artery on the right side, like this, before the procedure. And you can see very tortuous, let's say, serpentine stenosis on the right, and there was no good collateral flow from the left side. As well from the posterior side. And you can see the perfusion CT. So is it really good candidate for only best medical treatment? I'm not sure. So definitely for us, this is the good candidate for angioplasty. So we catheterize, we cross this extremely high-grade, let's say, pre-occlusion stenosis with catheter. Usually, normally we just go with the guide wire, but in this particular case, it was really necessary to use a microcatheter. And we perform angioplasty, and then after after angioplasty. So usually, if you wait a few minutes, you can find that the degree of stenosis is a little bit higher comparing to immediately on angiogram immediately after angioplasty. And then after we perform the stent, and this is the final result. And you can see the angiogram, and you can find that middle cerebral artery territory there is no delay in this territory, no more. And you can compare before endovascular treatment and after. You can see the stent and no distal emboli. There was no access injury, and this is the perfusion before and after the procedure. And what is the advantage of this comparing to bare metal balloon mounting stent? For me, it's good that we can do follow-up by magnetic resonance, because the artifact is very low, like here you can see, and there was no restenosis. And this is the contrast-enhanced magnetic resonance, and the patient was without any symptoms. And regarding the antiplatelet therapy, nowadays we have new molecules. Control was discussed, but we still use clopidogrel. Just there is simple reason. There is a good access for the patient, the price as well, and there is no restriction to prescribe the clopidogrel compared to other molecules in my country. But please keep in mind that if you have the patient with, for example, age more than 75%, you should avoid prasugrel. If you have a patient with body weight less than 60 kilograms, it's usually recommended to avoid to use the prasugrel, or at least you need to reduce the dose. And as well, you can, if you find some resistance to clopidogrel, you can switch to ticagrel or prasugrel. But basically, prasugrel is not recommended if there was a recent ischemic event. And so, what we can conclude, we still do stent angioplasty in selected patients, especially for symptomatic stenosis, more than 70% with hemodynamic and unstable, with a failed best medical treatment. And the results are dependent on operator experience. Regarding the timing of the procedure, it's recommended to perform after 21 days after last event. The technique is really important, and we should also focus to medical management. And please do, if you have access to testing, what we do, we test every patient before the procedure for resistance of antiplatelet therapy. So thank you for your attention.
Proceed. Thank you. Do you have any questions from the audience? No. So we do a 15 minutes break, and then we continue. Thank you very much.
Thank you.
Thank you. Thank you for the brilliant.